Hello, everyone. Good evening, and welcome to yet another episode of ICPA Clinical Series. And as you all know, ICPA Clinical Series has its own philosophy. Each episode, one clinical challenge. And today we have a special occasion, Women's Day. And to commemorate Women's Day, ICPA has planned a special series of lectures. Throughout the month of March 2022, we will be running three lectures by eminent women clinician educators. So we have planned three lectures. The first one is today, that is the 10th episode of ICPA Clinical Series. And the second is going to be on 16th, and the third one is going to be on 24th. You must have all seen the flyers and the posters of the three events. All right, coming to today's event, we have decided to keep today's topic on endodontics because just a few days ago we had Endodontist Day. So we decided to choose a woman endodontist who is doing exceptional work in endodontics, for which we chose Dr. Hetal Buch from Rajkot. Dr. Hetal Buch is a certified microscopic root canal specialist. She is a BDS from Bharati Vidyapit University, Pune, and she has been practicing exclusive microscopic endodontics since 2013. She is a key opinion leader for ZEISS Germany. Dr. Hetal has made international presentations at root summits in Berlin, Dubai, and Chennai. She has also presented at the IFEA World Endodontic Conference in 2021, just last year. And coming to her practice, Dr. Hetal Buch is the co-director of Sanjeevani Advanced Implant and Microscopic Dental Clinic in Rajkot, Gujarat. And she and her husband, Dr. Nigam Buch, my very good friend, very well known implantologist, were the pioneers in bringing microscopic endodontics to Rajkot. And Dr. Hetal Buch is the only lady dental surgeon from India to get the place as a gold member in the International Microscopic Dental Club and 3D cleaning project in endodontics. And I would like to end this introduction of Dr. Hetal Buch by mentioning a special mention for the award she won recently, just a few days ago, Indian Dental Divas Award that she received in Mumbai. So hearty congratulations to you. So this is the best tribute we can give to women dentists, women entrepreneurs, and all the women leaders who are doing great work in their respective fields. So I welcome Dr. Hetal Buch to this show, and Dr. Hetal, the show is yours.
Big thank you, Dr. Rajiv Chidgupi sir, for an excellent introduction, and also Shrishti and the entire logistic team of ICPA Health Products. Especially, I will start my presentation by thanking all my teachers. The beauty of teaching is when they sow the seeds of magnification in my mind. So I'm able to be in a position to present this presentation to all of you. So big thank you to my teachers, mentors, and gurus, my parents, my in-laws, my husband, who is my main teacher throughout. So with this Guru mantra, Guru Brahma, Guru Vishnu, Guru Devo Maheshwarai, Guru Sakshat Parabrahma, Tasmai Shri Guruve Nama. And we start microscopic endodontics. Success is in details. Now, when you look at microscopic endodontics, it's a very good incident I can remember from when I attended one international congress. The endodontist there shared this incident with us. Is like he went for a congress internationally. So on the immigration department, the immigration officer asked him, "What is the meaning of endodontics, and why you have written microscopic endodontics? What is it like? What are you exactly doing? So you are a doctor and a microscopic endodontist." So the doctor told him that I am a neurovascular surgeon who replaces the diseased nerve endings of a tooth and replace it with an artificial nerve ending to save the life of the natural tooth. So the immigration officer was so impressed. He's like, "You are just like a cardiologist, a cardiac surgeon. Like he uses stent." yeah, to give life to the heart. The same way you are giving life to the natural teeth. So we are neurovascular surgeons of the teeth, and saving the natural tooth is our aim. So this is the how we work with microscope. That is the pre-COVID era, and during the peak of COVID emergencies, when we were used to wear all the headgears and everything, cover the microscope, and keep on working. And this is 2022, and we are with the microscope and with indirect vision, rubber damology all together. With this, we'll start into the details of magnification. Now, whenever a third year, final year interns, or just after internship, our associates, they come to me and ask me, ma'am, I want to start magnification. So these are the skills you need to conquer before you start the journey of magnification. Indirect vision, rubber dam applications, empathy, kindness, communication, tactile sensation, open mind, and connection with your patients. This is very important. See, indirect vision, rubber dam applications, and tactile sensation, all this goes hands in hand. I started my journey in 2007. We started our private practice. But from 2007 to 2013, these are the things we were taken care of by me and my husband. He was the one who pushed me. Like, you have to start rubber dam He just gave me one fine day, he just gave me a rubber dam kit and he said, you just start off. I was like, I don't know how to work this. That's okay. You just start off, you will learn it. So it is in your mind. Your mind should be open to accept that yes, it can be done, it could be done, and it should be done. Empathy, you should think yourself in place of your patients. You should feel the pain of them. Then your hands will work automatically in a minimal invasive way. Kindness, kindness is very important in our profession. We have to be slow in our treatment plans. Communication, what the patient needs, wants, all these things we need to give time. Tactile sensation and rubber dam application. If you are working in a field which is filled with blood, saliva, and all the tongue is coming in between, you have to retract the cheeks. And if the cheek muscle is too strong, your hands will be paining. Imagine how will your tactile come into your picture. How will you feel the apical one third of your canal in your hands, in your fingers? So rubber dam is a must. Third year, final year, interns, you should have your own rubber dam kits if the college is not giving you. Start doing it. It is just a piece of cake once you start it. So connect with your patients, keep your mind open, and with these skills, you can conquer magnification. These are the basic skills needed. So this is the video where you can appreciate how a precise removal of dental caries can be done. A small pit caries, which is this is 25x magnification. You can see the removal precisely, minimal invasive way, and you can see what you are doing. This is direct vision. It's lower posteriors. Sometimes you can use direct vision in such teeth. Yes. So coming to elusive MB2 canals. So I'll be giving overview of the videos once in a while in between to make you understand how the magnification works. This is mostly elusive MB2 canals. Why they are elusive? They are found in maxillary first and second molars, and all the incident is 96%. That means each and every case you will have an MB2 present. So why MB2 is important? Like, if you are missing a MB2 canal, there will be always a sensation of pain on hot and cold and hot foods and drinks. So MB2 canal negotiation is a must. Now dentine around the orifices need to be preserved. That is known as preservation of pericervical dentine. So all these points are to be kept in mind when you negotiate MB2 canals. So pericervical dentine is the dentine around the neck of the tooth, where your MB2 canal is sometimes located. Now in parts where lot of dentine thickness is present, at that times MB2 canals are hidden below the dentine thickness. That time preservation of pericervical dentine becomes a must, as it is important for your ferrule and also it improves fracture resistance. Now, if you ask me, the very easy way to locate MB2 canals is with magnification. I'll show you in the next case. This is the minimal invasive protocol that I follow in my clinic. This is a case pre-op radiograph. You can see a pre-operative radiograph here. Now here in this case, you can see the thickening of the mesiobuccal root. When the thickening of the mesiobuccal root is more as compared to the other roots that you can see. Now this is upper left 7. So 7 second molars usually have MB2 in a very less incidences. But in this case, MB2 was present and it had a separate portal of exit. You can see how the pericervical dentine is preserved in this case. And here I want to emphasize on observation of pre-op radiographs. You should observe the pre-op radiograph in a very refined way in mesial and distal direction of your angulation of your x-rays to understand the separation of the canals before you start any case. So if there is an eccentric location of the canal, there will be always a doubt of MB2. Now, most of the MB2 canals, 95% of the times, can be located under rubber dam isolation with indirect vision under magnification. In this case, Zeiss OPMI Pico microscope that we have in our clinic, we use it to situate, that is magnification aided root canal therapy. So MB2 canal can be located between the main mesiobuccal canal and the palatal canal. So you can see a gray area here. You have to locate the along this line. Again, in a bit, we will understand how you have to go around that area with your instruments. The next line of progress for MB2 canals will be difficult when we negotiate the MB2 canal. The first point that is there after we find the MB2 canals is negotiation of the MB2 canal as it hits the mesiobuccal wall of the main mesiobuccal canal. So watch winding and pre-curving of files is a must. Also, your handpiece can be moved from the distal to mesial angulation to negotiate the MB2 canal and remove the dentine overhang, but again, it has to be done under magnification. Another one test that can be done is champagne test or bubble test. Now, if you are doing this with a naked eye, you won't be able to see such a refined bubble here, but you will be able to pinpoint bleeding spot or bubble around the MB2 canal. Now, if you soak the chamber with 5% hypochlorite, the area where MB2 is present, there will be bubbling effect like this. Now, here you have to negotiate with pre-curved 10 number files. The 10 number hand file is your golden file. It will allow you to go in the direction that merges with the main mesiobuccal canal, or it has a separate portal of exit. So there your tactile comes into picture. Now here rubber dam comes into picture, and at the same time indirect vision. So again, my first point, indirect vision, rubber dam application, tactile sensation, everything goes hand in hand. So again, if you don't have all these things, you cannot use magnification. Microscopes have coaxial light, so which illuminates the chamber to such an extent that the MB2 canals are visible even without negotiation. So that is how the pericervical dentine is preserved and excellent minimal invasive core buildup is done. Here, some cases CBCT also can be used, but CBCT has some limitations when excessive amount of dentine is deposited around the pericervical area. We'll go in detail in a bit. Another case where MB2 was located but was not obturated, what was not there in the, because the MB2 is very small canal and it is very tightly placed. So sometimes during the cone fit x-rays, you are not able to take a cone fit x-ray for the MB2 canal. So in this case, it was bifurcating on the mesial aspect of the mesiobuccal root. Again, a very good case where we will be seeing some of the cases where it is difficult to locate the canal, but very easy with magnification. So here the MB2 canal is merging with the main mesiobuccal canal, but it was on the axial wall Because of the excessive dentine thickness, the whole part was covered with dentine, which has to be removed with a burr under magnification and rubber dam. And then the MB2 canal is negotiated from the mesial aspect of MB2 canal, merging to the main mesiobuccal canal. So there is mesiobuccal canal, distobuccal canal, palatal canal, and MB2 canal. Here, one clinical tip I can give you: we when we obturate the tooth, we put the when there is such a huge curvature of MB2, we put a 10 number K file into the MB2 canal, obturate all the three main canals, and in the end, obturate the third canal. This will help you to clear the MB2 canal orifices, keep it clear from the sealers, and it is very easy to obturate it. You can appreciate the multiple portals of exit here with the rubber dam application and three-dimensional irrigation and obturation. So that is how the negotiation of MB2 canals is done with 10 number K file. Please don't note and don't use any higher number K files. 15 in not allowed. Here only 10 number, 8 number or 6 number K files can be used if it is too tight, if there is only a fin. But 10 number K file is the golden file of rule to negotiate the MB2 canals. Again, the K file in the MB2 canal, negotiation under rubber dam and magnification. This is indirect vision. This is the video showing how the MB2 canal is negotiated with Pro Taper Gold. You can see the debris coming out from the MB2 canal, and at the same time it is getting negotiated. Now Pro Taper Gold is a flexible instrument. As you can see, you can easily negotiate the canals. Here you can appreciate the depth of the field of the microscope. You can see the chamber of the tooth with main mesiobuccal, distobuccal, palatal, and MB2. This is at 25x, the maximum magnification. Also, preserving pericervical dentine is a must. So, negotiation of MB, MB1, MB2, and MB3. So, main mesiobuccal canal, 2 and 3. Sometimes you have 3 canals in a line. We'll see in detail in a bit. So, this is the preservation, and the law of symmetry is followed. This is in this case, nothing has been done. Only excess opening was done, and no negotiation of any canals, and just soaking and dissolving of the pulp tissue from the chamber, and you can easily locate an MB2 here. You can easily see the main mesiobuccal canal, a line drawn from main mesiobuccal canal to palatal canal. Midway is your MB2. That is your distobuccal canal. That is after cleaning and shaping, and that is the before obturation. Crystal clear chamber. So, but the bifurcation of canals is very important. This is the law of symmetry. The MB2 canal is always located in the line drawn from the main mesiobuccal canal to the palatal canal. So you have to go around that line. You can see the soaking of the canals in this. The whole chamber is soaked with sodium hypochlorite. Under magnification, you can see all the 4 canals very nicely, and this canal is going and merging or bifurcating, whatever is the case, easily negotiated with magnification and rubber dam. So this is the video where you can see the dissolution from the chamber. Till now, don't use any hand instruments, no K files, nothing, till you clearly clear the chamber of all the tissue. After that only the orifice designing is started. The different aspects of MB2, minimal invasive protocol. This is natural symmetry. Always follow the anatomy. So the natural anatomy should be in your mind when you start any case. Beer and Brauman suggested this geometry. This aids in location of MB2 canals. But when you have magnification, it is very easy to do this. If a line is drawn from mesiobuccal canal to the palatal canal, and a line 2 is drawn from the perpendicular to the line 1 in such a way that it passes through the distobuccal canal, MB2 is located between crossing of both the lines. Sometimes a third MB3 is also present around these lines. Now you have to look for the MB2 canals around this bifurcation. But when you clear the pulp stones and you clear the chamber, the MB2 itself will come to you if you are using a magnification. There is no need to go and look for it. So that is beautiful chamber with merging canals and preservation of pericervical dentine. That is the X-ray of the all the three canals together, immediate post-op, these are merging, and immediate post and core. The beautiful compact composite restoration without any air bubbles. And I'll give one excellent clinical tip later on. This shows that success of any endodontic therapy depends upon the quality of cleaning and the entire root canal system. Therefore, it is important to have the adequate knowledge of anatomy, right? So, the scientists have described that any failure to locate the MB2 canals will lead to failure of the second mesiobuccal root of maxillary molars, the failure of the root canals. This is what we need to achieve: a separate portal of exit, a compact root canal filling. A clinical tip here: just remove 1 or 2 mm of gutta percha from the orifice and make the core buildup compact. There should be 3D cleaning and shaping, 3D obturation, core buildup from orifice 1 to 2 mm down the orifice to the coronal aspect of the tooth, giving it an excellent hermetic seal, at the same time preserving the pericervical dentine. Now coming to the pulse stones. Again, pre-op radiograph is a must. You need to see the pulse stone here. You need to see the radiolucency here. You need to see the patency here. According to this, your treatment will go ahead. So mind mapping. When you take any X-ray, just see in 2 dimensions from mesial aspect, distal aspect, and main X-ray. And you can negotiate the pulse stones in your mind before you start your case. Like in implants, you plan your prosthetic part before you start the case, right? The same way, you have to plan your case in your mind when you start when you see the first X-ray. You have to observe the case, because these discrete calcified masses sometimes are embedded into the palatal canal, and they can lie freely within the pulp chamber and embedded in the wall, giving it an attached pulse stone. And I should tell you, attached pulse stone is very difficult to remove if you are not using the proper protocols, because the burr goes and hits there all the time and you are not able to move around the stones. The patients which we get these stones are between 50 to 70 years old, and sometimes even young adults. Now, long-standing dental caries, large restoration, traumatic occlusion, aging, attrition, abrasion, erosion, dental injury, so many cases, so many reasons for these stones, but they are very common. So in this case, this is a very good case where CBCT was used to detect the pulp stone. It was a referred case. Now there was a carious exposure below than old restoration, and there was a pulp capping was done with MTA. The patient has had irreversible pulpitis and also pain on chewing. Now, during CBCT examination, we can see that there is some calcification there, and there is a patent canals there. Now, the patent canals, one of the canals had pulp stone inside the canal. So here CBCT helped me, as we have in our clinic. Very recently, in just 1 month, we did this case, and it was very easy for me to carry out the case with the help of CBCT. So that is pre-op X-ray, again a must, a carious exposure there, and an MTA placed there, which this is under magnification, indirect vision, rubber dam isolation. The MTA in the chamber is cleared. You can see the dentinal overhang over here. Now this has to be removed. Then the orifices are here. Here is mesiobuccal, here is distobuccal, here is palatal, and there might be an MB2. I always go into a case, when I start a case, I always go that there will be an MB2, or I might find an MB2. So I always go very delicately around this area, so that I don't want to block. If there is upper left or upper right 7 means MB2, if at all it is present, it will be very tight and very small. So accordingly, you move ahead, dissolve the pulp stone nicely with your sodium hypochlorite, and you can note the stone is dissolving. There is a carious exposure there, which we saw in the CBCT and RVG, and you can see the compact, beautiful restoration. The restoration was done very nicely, and the MTA placement was also perfect. Now you can see the stone is dissolving. Now the stone is loosened and it is out. The palatal canal, half of the palatal canal, like coronal one third, was with the stone. That is the shape of the palatal canal. It came out in one piece with the remnants of the pulp tissue. Now you can see the crystal clear pulp chamber with small MB2. Now this small MB2 was very tight and it was difficult to negotiate this canal. So 6 and 8 number hand files were used to with watch winding motion and different directions to clear the debris around these canals. Now coming to, this is after cleaning, and again I tried to preserve the pericervical dentin orifice designing. This is not straight line axis. The orifice is designed in such a way that pericervical, the neck of the tooth dentin, is saved. The MB2 canal, again that excellent clinical tip that I told you, file in the MB2 canal, obturate the main canal, see the portals of exit, and then it is over. You do a complete core buildup, compact, tight, without any air bubble. This is an excellent clinical tip you will not get in any book. This is pure clinical. Now this again a case of pulp stone. Now this is a very beautiful case. You can really appreciate the attached and unattached pulp stone. Extremely important to observe the pre-op x-ray, clear cut distinct pulp stone inside the chamber, plan your treatment, mind mapping of the anatomy, everything very important before starting the case. Now, when I opened the chamber, you can see I opened the chamber. You can see the mesiobuccal, that is inverted triangle, the mesiobuccal, distobuccal, and palatal. That is unattached pulse stone, that is attached pulse stone inside. Sorry. TC11 bore is my favorite. This bore is used to remove the pulse stone. Mind mapping of your case here. Clear the dentin overhangs only with magnification. Once upper part of the stone is cleared, next will be the attached part. Now the attached part of the stone has pulp tissue remnants inside that you can see. Now TC11 bore is my favorite. Why? Because you can go with that bore around the stone. You can see this radiolucency. You have to use this radiolucency in your mind to create a around the stone, to create a round around the stone with your tapered Fisher bore, that is TC11. But this bore will not work if there is no radiolucency here. You have to use this radiolucency, this space here between the roof of the pulp chamber and the floor of the pulp chamber has to be used, and the mind mapping of the case has to be done. That is the attached pulp stone, very clearly visible, indirect vision, microscope, magnification, and you can see how the pulp tissue remnants are there around it. So anatomy in mind, tentative location of, you should know there is an mesiobuccal here, there's a distobuccal here, palatal here, and maybe an MB2. So go ahead. That is clearance of the soaking of the canal. Again, minimal invasive dentistry. Pericervical dentin is preserved. Respect the natural tooth. The attached pulse stone is removed with the pulp tissue in it, and the chamber is crystal clear. Now the continuous irrigation is going on, and you can see the crystal clear chamber. This I have not gone with any hand files here. This is just pure magnification. You can see the canals are coming to you, the orifices are coming to you. You have to just design this orifice. It becomes so easy. Mesiobuccal, distobuccal, MB2, and a palatal. So mind mapping, orifice ready to be negotiated. Still no hand files are used here. Now the glide path and orifice designing and the further treatment will start. Now, if you have gone around here with TC11 in such a way that you go around this area, then you will block the MB2. So you have to be very careful in such cases. Beautiful MB2, magnification is a boon, pericervical dentin is preserved, everything is spick and span. Again, seeing is believing. This is post-op. Appreciate the canals which are obturated here, all 4 canals in one view. You can see the excellent vision here. Now, this is what I was telling. 1 or 2 mm of gutta-percha is removed and to give a focus, composite restoration, core build-up to the tooth, gives a beautiful obturation in 3-dimensional. A focus view. The pulp stone and MB2 together. So here you can see the pre-op of the same case and a post-op. So this is again a case of MB2, which we had upper left 7, which is severe curvatures. Now all the curvatures has to be maintained when you are cleaning and shaping. Again, magnification, rubber homology, and indirect vision together. You can see the focus view of main mesiobuccal, MB2, distobuccal, 1 mm or 2 mm of gutta is removed to give a nice core buildup. Now coming to Radix Entomolaris, this is an additional root in relation with mandibular first molars. These are distolingually located. Sometimes they are buccally also located. Then they are known as paramolars. Paramolaris. Now coming to the views. Now if you see it from the buccal view, the distolingual view of the distal canals, like distolingual aspect, will be this root. This root is tight to negotiate. Sometimes the curvatures are in the two symmetry, so you have to be very careful. You can ledge or break a file in this root if you are not careful while negotiation of these canals. And that is the lingual view. You can see the curvature. Sometimes it goes in S shape. We'll see in direct vision how it looks. You have to modify the axis, your axis according to the, in this video you can see the distolingual aspect, the distobuccal aspect, the mesiobuccal aspect, and mesiolingual. See, in magnification everything is opposite. Okay, so you can see here clearly this is distolingual root where the orifice designed. This is the distobuccal, mesiobuccal, and mesiolingual. And you can see, appreciate the isthmus here. This isthmus is very important. It has to be removed. All the collagenous pulp tissue has to be removed from the isthmus around this area and clean it up. This is calcium hydroxide inside the canals in the second appointment, how it should look. You can see the distolingual, distobuccal, mesiobuccal. So actually a rhomboidal cavity goes into a trapezoidal cavity. So you have to access your access opening should be modified according to your root. See the collagenous under magnification, indirect vision, and rubber dam isolation. You can see the collagenous tissue inside. The dissolving of this, you can see the distolingual root, the distobuccal root, mesiobuccal, and mesiolingual, and all the isthmus is crystal clear. This should be your vision after cleaning and shaping. This is what we work for. Again, a crystal clear chamber. Till you get a crystal clear chamber, you're not supposed to start your obturation. That is a cone fit X-ray. That you can observe the curvature of the distolingual root, and that is post-op with a compact filling. Now, this is a very interesting case. This is a retreatment case, but it is a Radix case. That's why I incorporated it. You can see this patient had pain on drinking and eating hot foods. There's a miss distinctly. If you can observe this tooth, just a pre-op X-ray, nothing else, you can see there is a root here which is missed. Okay, and there are ledges here. So under rubber dam isolation and with magnification, indirect vision, we clearly cleared all the ledges and reached till the apex. Clear the ledges. Cleaning and shaping is done. You can see the internal three-dimensional irrigation, due to which all the extra canals are filled, and that is post-op with the crown placement. Now the surprising part in this case was also the adjacent tooth. That was also a Radix. The first one was Radix, which was done first, and the adjacent tooth was also Radix. But you can see here, you feel that it's a perforation. The filling is going in the perforation area. It is going in the furcation area. But no, this was the distolingual root that was distinctly present, and it was a paramolaris case because it was buccally present, and that is after retreatment, cone fit, that is post-op, and that is after crown placement. Now, this patient came to me just recently for the other side treatment. I got a 5 years follow-up for this case. I was so happy to see this. This is the moment that we work for. This patient is so happy and chewing on this teeth for 5 years. So this is the way we work. That is the patient positioning. That is the microscope positioning. That is the assistant. That is how I do documentation. The Previously, my assistants used to, retract the tongue and retract the cheeks. Now they are so happy. They are very relieved. Like, their work is reduced. This is exclusive microscopic endodontic operatory with Zeiss OPMI Pico. That is our brand new renovated chamber. So it is a pleasure when I work. So when I work with so much pleasure, it puts perfection in my work and I improve. And I am a constructive critic of my work. I keep on improving. When I'm free, I dissect the extracted teeth and see the curvatures. It is fascinating to see such beautiful anatomies. So these are the best friends: Carl Zeiss PMI operating microscope with Mora technology since 2013, and the latest one is Castream. So this is our microscopic dental club. So we make different dentistry to make dentistry different. That is the motto of the club. That is all the dentists from all around the world. Recently, we are coming up with night eye pluggers to do three-dimensional obturation for such difficult anatomies. So they will be in the market soon. This is my 3D cleaning project, Endodontics family. So we are the family from all around the world, all the endodontists together. I feel this statement does work for me and Nigam both. We just keep on sharpening our skills. We want to be so good at our work that we want to keep on seeing our work all the time and keep spreading happiness with our work. That is against the scope. That is Mela Class B complete sterilization workstation that we have in our clinic. That is the implant operatory with the digital OT LED technology. That is our renovated chambers, PrimeScam AC intraoral scanner, and CS9600 CBCT, our latest acquisitions in our clinic. So with this, I'll end my presentation. These are the things I want you to take forward. Like, knowledge is the key, magnification is the key, and there is no substitute to hard work. Thank you.
Thank you. Thank you, Dr. Hetal. It was amazing. You covered
Thank you.
all the aspects, and I think you took only 30 minutes. We started at about 9:35 and you finished by 10:05. And in 30 minutes, you covered so beautifully all the clinically relevant areas. And I don't know whether there are any questions left for you to be answered because you have covered almost everything. Let me just read out the questions that have come to us. Actually, we were to have a co-host, Dr. Ami Joshi, with us, but because
Yes,
of some technical problems she had, I have taken over and I'll be asking the questions. And
right.
I'll just read out, and if you have already covered it, let us move to the next one. How to
Sure.
remove instrument from the canal? I think you have told about that. What are the precautions we should take prior microscope guided endodontic access cavity preparation?
That is
What is
your
the role?
pre-op exercise. Yeah.
Yeah. What is the role of CBCT in microscope guided endodontic access cavity preparation?
Yeah. So CBCT guided endodontics is like when you are doing a case, like you are starting a case. A pre-op CBCT will give you an overview idea whether you are encountering pulse stones or MB2 is present. Sometimes thickening of the dentine will overview your CBCT image, and you are not able to see an MB2. But then pulse stone and all are quite visible. Even vertical root fractures, if they are quite eminent, can be captured with CBCT. And at that time, whether to go in for a retreatment or to stop and extract the tooth, that particular positioning you can take for your patient's benefit.
So the decision making happens at the level of CBCT diagnosis itself.
Yes, yes.
How can we manage coronal and angular deviation during preparation of microscope guided endodontic access?
Coronal and
Angular deviation. I don't know.
angular like if he or she is asking about indirect vision. So when you are working with indirect vision, your coronal and accessibility is such that you have to go along the axis of the tooth. It is not your indirect vision is such that the axis of the tooth has to be followed. Your burr cannot go in the other direction. You have to start your access cavity preparation in such a way that your anatomy should be in your mind. So in indirect vision, mesial will look distal and distal will look mesial. So that overview should be there in your mind. So pre-op x-rays, proper observation and diagnosis of the case before you start a case. You can see the tooth, you can observe the tooth if it is big, or if it has more number of cusps. Always extra canals are present, because where the nutrition will come. See, there is a more space between your main mesiobuccal canal and palatal canal. There is always a chance of MB2, because that part will get nutrition from MB2, right? So that all things should start coming in your mind when you just observe the case. First diagnosis, when you first see the patient, the first diagnosis and all these things should come in your mind. So
Okay.
mind mapping of the case, mind mapping of your decision, mind mapping of your treatment, and mind mapping of how you will go around the treatment of this case, and with the indirect vision, that will help you.
Okay. Great. So the next question is, how does the use of microscope affect the general pace of practice? Is it feasible to use microscope endodontics in every RCT case?
Yes, definitely you can use in every RCT case, and you should use it, right? Because
Yeah.
rubber dam application and magnification goes hand in hand. So that's what indirect vision, rubber dam application, tactile sensation, all these things has to be conquered. Then you can go towards magnification and your microscopes with loops or microscopes. But again, when these things are in your hand, then it becomes very easy in your routine practice. Then,
Okay.
but again, your practice should be appointed base. You cannot just take up each and every patient one by one. You have to be appointed based very systematically and in a very organized way. It
So
has
should
to
be
be
a planned. It should be a planned appointment, and the treatment
planned.
plan should have been done beforehand with
Yes,
all the
everything has to
investigation.
be done beforehand. Then you can do each and every case with a with microscope and rubber dam technology.
Okay. 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 What is the success rate in maxillary molar root canals in which we are not able to negotiate MB2 canals?
The success rate is again negotiate, like it's a debate type of thing. But then again, MB2 canals, if they are thick and if they are missed, as I told, pain on eating and drinking hot foods will keep on coming, and within 1 year or 2 years, the success rate, sometimes the main mesiobuccal canal is such that it is ribbon shaped, so it will have a small fin. So when you clean the main mesiobuccal canal in a very beautiful way, and if you have missed that fin, the during your irrigation protocol, the fin will be taken care of.
Okay.
Then there won't be any issue. So
Okay.
that is the way how the canal is located, how is that portal of exit, whether it is merging with the main mesiobuccal canal or it is having a separate portal of exit. All these factors determine your success.
Okay. Please suggest me a right book of reference for beginners before using Lobomed microscope.
Any microscope, Lebomed or XYZ, you can read Cohen, you can read practitioners from endodontics. You can give my email address. They can mail me. I will write down the number of books I read during my free time, and I keep on reading all these books.
What
This
we can
is
do is, Dr. Hetal, you can give me the links. You can just give me the reference book, the names of the books. What I'll
yes,
do is I will put in the chat section of Facebook video where it is going
sure,
live, and also on the YouTube, so people can make use of your inputs
yes,
that will come after
definitely.
the lecture is over.
Yes, definitely. I am reading recently Clinical Practices in Endodontics. That is also a very good book. It has all the magnification features in it. So I'll write down the name of the book definitely.
Okay, okay, great. How to identify pulp stones in the pulp chamber during access opening?
That we have already covered in the
Yeah,
lecture,
in the
how
lecture.
the identification. With magnification, you can do anything.
Okay.
Only with magnification, it is a piece of cake to identify per stone or remove it. So
How
even
to
attached,
remove
not attached.
how to remove iatrogenically pushed pulp stone into the orifice of the canal.
Yeah, so heterogenically removal means the doctor must have pushed the stone during the removal of the stone with the burr. So what happens when they push, they try to take it out, but instead of that, it pushes in the palatal canal, mostly in the palatal canal, because palatal canal is big. It's a big canal, so the stone pushes inside the canal. So as it is, if it is pushed, it is loose, right? So with an ultrasonic tip, you can just go around the stone and it will loosen and pop out. Pushed means it is loose. If it
Yeah.
is not loose, then you have to go around with a tapered Fisher TC11, again with magnification, because TC11 is very sharp burr. If it goes into the furcation area or anywhere else, you will create perforation. So with
Okay.
magnification only, and with maximum magnification, I use that burr. So that precise cutting of the stone can be done.
Okay. Okay.
Yeah.
Great. Compare how do you compare loops versus microscope? Where do you use TTL and other loops?
Any loops and microscope, only one difference is there. When you are working with the loops, your head is tilted. A little bit tilt is there with your head. But when you are with microscope, your head is stable. The microscope is static. But when with we have a Mora interface, the Mora changes the microscope according to the quadrant we are working on. So what happens when we are working with loops? If you change your head position, everything will change. Your magnification is gone. You have to again, positioning, because I have been working with 4.3x loops for about 6-7 months before I got my microscope. And
Okay.
every day, afternoon 1 p.m. after my first session, I had headache,
Oh,
severe headache, because it is very heavy. 4.3x is very heavy for my head and my things. So, and continuous working, 5-6 hours continuous working with those loops, it's very difficult. So microscope gave me a beautiful life,
hmm.
clinically and my health wise. My spine is erect, my posture is perfect, and I'm enjoying my work and doing precision dentistry.
Yes.
Yes, so
And
this is the main difference.
what about the expenditure and investment that many people ask about? Beginners who are doing good root canal treatments, but they want to get started with microscopic endodontics. They are all
Yeah,
bothered. They are all worried about the expenditure.
yeah, so true. So that's why even I had that problem. So what we did, we started with loops first. So that, because immediately you start with microscope, the orientation is a problem.
Okay.
So from 4x to 25x, from lowest magnification to highest magnification, when you go and you don't have orientation, you will not use microscope. You will feel like it is, why I have bought this.
Hmm.
I should not have invested so much. It is just lying in the clinic like a showpiece. If you literally want to use a microscope, you have to start with loops first, so that you get orientation of your head and your clinical know-how. Because at minimum magnification, lowest magnification, you get orientation of hand-eye movements. You have an orientation of your clinical field, the judgment of your treatment aspect. Then you shift to microscope. So by that time, your things, you are planned, right? Your finances are planned, and always wait and go for the best, I feel.
Okay.
Because the microscope, only two things are important: your lens and your maneuverability. If it is static, it is useless. We, for
Okay.
dentists, we need movable. We need the maneuver of the magnification according to the quadrant we are working on. So that is very important, and your lens.
Okay.
So
So
all these things
basically, the transition is always gradual from loops, then
yes,
you move to microscope.
yeah, because it is a steep curve of learning.
Okay.
You cannot just jump to microscope just for the sake of microscope. You have to learn the orientation from 4x, 6x, 1x, 25x. At 25x, when you start moving your hand according to the anatomy of the tooth, that is the point you start working.
Okay.
That is the point you start enjoying your life, your clinical life.
Great. The next question is, what is the ideal or recommended position of dentist and the patient while doing procedures under microscope?
Yeah. So the patient's head should be at our lap area, that much reclined, and the microscope should be on the patient. Now, during that time, first patient positioning, operator positioning, and then magnification microscope comes in the picture. Because according to your height and according to your elbow height, the patient height will come, and
Okay.
accordingly the magnification comes. So first, overview 4x pay on 4x, we do the overview of the treatment aspect. So magnification and rubber dam. So what rubber dam helps us, rubber dam helps us to focus it. You are looking at two root canals, canine, two canines you are doing together. You focus your magnification at 4x. Yeah, that is your main focus. Now you are going to do a left root canal 3 and right root canal 3 together, because single rooted tooth can be done in a single appointment, right? So magnification helps you in such a way that both the access opening you can do simultaneously.
Okay.
Yeah, and precise. So one canine you can focus at 25x with fine focus, focus it nicely. That is your main focus. Then from 4x to 25x, even if you move anything, it will be remain crystal clear.
Okay.
So that is a clinical tip. At 25x, when you are using microscope, you are used to microscopes, you are used to magnification. At 25x, focus the tooth. Then do the fine focus. Once that you have achieved, then you move the magnification, it will remain the same.
Okay.
It will not vary unless and until the patient moves. That's why again that point comes into picture, connection with your patient. If the patient also moves a little bit, your focus will go, but at
Then you have to
25x,
fix.
not at 4x.
Okay. Okay. Okay.
4x you can do anything, it is quite easy maneuverability.
Mhm.
So rubber dam application, local anesthesia, all this thing can be done with 4x.
Okay.
So I do everything with 4x initially. Then once the treatment focus is done, then at 25x with fine focus and maximum focus with interpupillar distance, you should see a one image. When that one image comes, that time we are ready for the treatment aspect. Then depth
Great.
of the field of view, everything comes into focus. Yes.
The next question is, what is that first and the most important approach to find MB2 you can give to beginners?
Magnification.
First and the most important approach to find MB2 you can give
Yes.
the best advice.
Magnification. You
Okay.
should
Okay.
use loops. You should use magnification. It's very easy to find MB2 with so many factors that I made them understand during my presentation. These are the factors like line drawn from the mesiobuccal main canal to the palatal canal, arbitrary canal. Without magnification, all these things are possible. But then with magnification, no need to do anything. The
Yes.
MB2 will come to you. The MB2 is visible, very much visible once you do a proper access opening, and you just remove the dentine overhang with your TC11 bore, or even if you are using ultrasonic, so that will be very easy to negotiate. So no need to go and find MB2. The MB2 will come to you. It
Okay.
is so easy when you start using magnification.
Okay. So the next question is, what do you recommend with surgical loops before going forward to operating microscope? That is, what is the minimum time period or the number of cases, number of hours? What is that recommended period during which the person should spend with the loops before he transitions to microscope?
Yeah, microscope. So now this is a very good question. For me, it was like within 2-3 months, I was tired with loops. I wanted more. I want more magnification. With the experience and with the loops, I was tired. Like I had a headache every day. I told you at 1 o'clock I had a headache because of the heaviness of the loops. 4.3x size is very heavy for me at least. So then with microscope, I was thanking Nigam like anything. Like, thank you so much that you gave me this mic. This is the best gift you can give to me. You know. So every day, I should also thank Dr. Satish Bhalgat, the IDI group, that we
Yes.
went with him to Germany. We saw this microscope coming from a small chip to a big, what is it here. And that time, to think to import that huge microscope from Germany, that Zeiss factory, to Rajkot, was a huge task, but we did it
Great.
because we were so enthusiastic. When I started working there in Germany, when I started working, I was glued to that microscope. I was not ready to leave it. It was so beautiful to work there. And
Great.
Dr. Tom Cross and Dr. Wallner, they explained every aspect of magnification in detail. So we were 16 doctors, Dr. Komal and everybody was there with us, Dr. Nigam, everybody, we were together. And we understood the basic microscope technology from basic to advanced, how they make it. It
So this
was
was in
awesome.
2013. 2013.
2013. That is the turning point of our life, clinical life.
Okay. So you completed a decade then, 2013 to 2022. It's been
Yes.
10 years now.
It has been a beautiful journey, I must tell you.
Great, great, great. I think we are done with all the questions. You have covered everything. There are many more questions, but I think you have covered all of them in your lecture only. Only those questions which I thought look a little different from what you covered, I asked you, but you have answered them as well. And I think we have come to the end of this lecture. Thank you, Dr. Hetal, for this enlightening
Thank
session.
you so
You
much,
spoke
sir.
beautifully and you shared your clinical knowledge from your extensive work that you have been doing, wonderful work that you have been doing. And I wish you a lot more success, many more awards like what you received recently. And
Thank you.
thank you for being a part of ICPA's commemoration of Women's Day. And we would like to have
Thank
you
you so
again
much.
soon in one of our future episodes. Thank you so much. And as
Thank you,
I
sir.
said in the beginning, we were to have Dr. Ami Joshi also here, but we missed her because of some technical problems. It's okay. Please convey my best wishes, my regards to Dr. Nigam Buch as well.
Sure, sir.
So we
Thank
have come to the end of this show. Thank you, viewers. Thank you for being a part of this show. And this is ICPA Clinical Series. Each episode we bring up one clinical challenge. And remember that in this month we are having all women speakers, women clinician educators. So there are two more episodes, episode 11 and episode 12, which are going to be broadcast on March 16th and March 24th. You'll all be receiving the notifications on the social media. Thank you so much. Thank you, Hetal, once again. Thank you once again for
you.
this
Thank you,
beautiful
sir.
show.
Thank you,
Thank
sir.
you. Good night,
Thank
everybody.
you
Take
to
care
the
of
whole
yourselves.
team. Yes, whole ICPA team. Thank you so much.
Yep.
Honored. Bye bye.
Bye bye.